have a center with all these areas. While they often overlap and almost always require a collaborative, interdisciplinary approach. And we intentionally use the skills of all of our associated providers to provide the safest, most effective treatment for sexual, relationship, gender, and menopause concerns. We also like to meet clients where they are, with multiple access points, wherever a client feels comfortable starting, whether that's a medical assessment or a therapy relationship. A little bit first about me and my story. I came to medicine as an older student from a career in theater. I chose Rochester for my family medicine residency because of the department's focus on the psychological and social aspects of primary care and medicine, right here in the home of the biopsychosocial model. And perhaps you didn't know, the biopsychosocial model was developed right here in Rochester in the 1970s by a University of Rochester psychiatrist, George Engel. It's an interdisciplinary model that looks at the interconnection between biology, psychology, and socio-environmental factors. So I met Dan when I was a chief resident, and this was on our first date. When he told me he was a sex therapist, I thought, this might be a really interesting conversation. And several years and ASECT conferences and sex therapy workshops later, I was really hooked on the field of sexology. Dan and I attended the European Society of Sexual Medicine School of Sexual Medicine in Budapest together, and I sat for the exam to become a fellow of the European Committee on Sexual Medicine. So now, in addition to my work with Rochester Center for Sexual Wellness, I teach medical students, residents, and in 2019, I started a sexual medicine clinic in the University of Rochester Gynecologic Oncology Department, Women's Cancer Department. So in medicine, it's really our patients who are our most important teachers. So a recollection of one of my first patients in residency. A large and imposing man who had been recently incarcerated. As I struggled mightily to control his sky-high blood pressure, to help him control his sky-high blood pressure and his diabetes, it became clear that his main concern was that ejaculation really hurt and had for a long time. There was no infection. He had been to urology and had left without a plan to manage this pain. It was affecting his erections and desire, and this was devastating to him. I went to my preceptors. I looked through my typical resources, and no one had anything to offer me. I knew there had to be more to know about this, and that I was inadequately prepared to help him. So, and it was also clear that while I was a pretty good student in medical school and in residency, this was something I needed to seek out on my own. Next slide. So, what is a sexual medicine specialist? And first, what is sexual medicine? Briefly, sexual medicine is the branch of medicine concerned with human sexuality and its disorders. Or as Dr. Charles Mosier puts it, the medical aspects of sexual problems and the sexual aspects of medical problems. Certification is available in Europe, that Fellow of European Committee on Sexual Medicine, for physicians from a wide variety of specialties, primary care, psychiatry, urology, gynecology, endocrinology, neurology, oncology, etc. There's no board certification available here in the US. And then the practice of sexual medicine here in the US tends to be siloed in the largely surgical fields of gynecology and urology, despite the fact that sexual concerns are often similar between genders and rarely require a surgical solution. And residency programs in urology and gynecology get little medical education in sexual function and dysfunction. It's a specialized knowledge base that providers generally have sought out on their own. Sexual medicine is really about understanding what's going on in an individual or in a relationship from a true biopsychosocial and sometimes spiritual perspective. We need a familiarity with a broad array of medical concerns and treatments to do this, not just concerns and treatments that affect the 1 square foot of anatomy below the belt. And we really need to be open to the non-physical, non-medical aspects of sexual concerns to begin to conceptualize what's happening with a person sexually. Next slide, please. So the interplay between these domains is understandably complex. And as medical and mental health providers, you may be familiar with the housing of sexual dysfunction concerns as outlined in the DSM. But the DSM doesn't address the fact that there's often a biological aspect to symptoms. And this really reflects a now outdated mindset that sexual problems are simply psychological. And this is just not the case. And it's not reflective of the last 25 years of sexual science. International medical societies devoted to the study and treatment of sexual issues came together to describe a diagnostic classification system that's more reflective of the current scientific evidence and best practices, and that will be used in the ICD-11. This new classification system recognizes that many aspects of sexual concerns are not different between genders and is more reflective of the mind-body social reality of sexual concerns. Additionally, the ICD-11 chapter on sexual health eliminates past guidelines that impose a normative standard for sexuality, and they've removed all categorizations that selectively target people who are sexual minorities with same-sex orientation or gender diversity. Next slide. This next slide just shows a listing of the ICD-11 in a whole new chapter devoted to conditions related to sexual health. Next slide. So what do I actually do? This is a 9-field tool to organize a sexual medicine assessment. I look at biomedical aspects that might include medications, treatments, surgeries, a change in hormonal environment, poor sleep, excess weight, or a long history of hormonal contraceptives. I look at psychological aspects that may be both within a person or within relationships. I look at sociocultural aspects. Obviously, this is a wide category that covers many elements, from addressing family, ethnic, religious, national beliefs, about sex, to addressing the special stressors and health risks of marginalized populations. It also may include wider cultural conversations about sex at critical junctures in a person's development, such as the purity movement in American Christianity. I would also add another category of spiritual to this assessment. And by spiritual, I mean defined by a sense of meaning and connection to purpose, or a feeling of oneness. Next slide. So which clients really benefit from a sexual medicine evaluation? Sexual pain is an example of a concern where a medical provider who has expertise in this area really needs to be involved. There are many biological causes of sexual pain, and it has profound individual, psychological, as well as relational effects. Lifelong early orgasm, also known as PE, which is orgasm typically within a minute or less of penile penetration. This is often does not respond to behavioral interventions alone. And there are many chronic medical conditions, as well as the medications used to manage them, that affect various aspects of the sexual response cycle. Sometimes the most convincing piece of information that I can use to help someone with diabetes get motivated to work on their blood sugar management is the profound effect that blood sugar has on erections and testosterone levels. Persistent genital arousal disorder, as Dan mentioned, extremely distressing condition in which a person has persistent and unwanted feelings of genital arousal that may or may not be relieved by orgasm. And sometimes, too often, the degree of distress with this condition can lead to suicidal ideation. There are neurological causes that can be explored and medications that can be helpful. There are 2 FDA-approved medications for premenopausal women with low desire and highly effective and safe testosterone supplementation for postmenopausal women. Sexual desire is also the first thing to go for men who have low testosterone, and testosterone replacement can sometimes be a game changer for them. We're going to discuss some kinds of cancer experiences in greater depth later this evening. And then there are some people who just don't want to pursue a psychological treatment, and they're really looking for a medical treatment. Next slide. So much of what I do is really education. A lot of myth busting around the physiology of sex. And sometimes the most healing intervention I make is telling them they are not broken. I also collaborate with other medical providers to find medication regimens that will allow a client to meet their sexual needs. For instance, some blood pressure medications have a greater impact on erections than others, and a medication adjustment may both allow a patient their erections and manage their blood pressure. And as I'm sure many people understand as well, this is also true of a variety of antidepressants. We do have medications that can help with a number of sexual concerns. And then pelvic floor physical therapy is a critical intervention also for a wide variety of sexual function concerns. The bottom line here is sexual science is really just beginning. And there are many more solutions than people realize. And in order to be successful, it requires a whole person biopsychosocial approach.